Welcome, everybody, to our 7th edition of our podcast. This is Dr. Tony Tarchichi from Children's Hospital of Pittsburgh. Again, this is our Pediatric Hospital Medicine podcast series. Today is a great one. I hope you all agree. Today's topic is community-acquired pneumonia. I do want to take a second because our last podcast guest was Dr. Ricardo Quinones in Houston, and of course, Hurricane Harvey hit Houston pretty hard. And now Hurricane Maria is hitting Puerto Rico. So to all of our colleagues, especially Dr. Quinones, who I did email after Harvey, and he's doing well in case anybody was wondering. All of our colleagues, friends, and families, everybody in the Houston, Florida, and now Puerto Rico area, we wish you the best. We hope for a speedy recovery. So there's no easy way to transition from a topic like that. So let's do our disclaimer. This podcast is intended for general, informational, educational purposes only, and is not to be considered medical advice for any particular patient. Clinicians must rely on their own informed clinical judgments when making recommendations for their patients. So just to remind you, it's been a while. I haven't done this since July. We've been busy with summer vacation and everything else. I am MedPeds trained, now Pediatric Hospitalist, director of our Pediatric Hospitalist Fellowship Program. We've been doing this podcast for a period of time, marching through all of the core competencies. I am fortunate enough today to be joined by Dr. Samir Shah. So Dr. Shah is the professor of pediatrics at the University of Cincinnati College of Medicine and director of Division of the Hospital Medicine, and he's an attending physician in hospital medicine and infectious diseases at Cincinnati Children's Hospital Medical Center. He also holds the James M. Ewell Endowed Chair in Hospital Medicine and serves as the vice chair for the Pediatric Research in Inpatient Settings PRIS network, which is a multi-center hospital-based research network, and we're going to be doing a couple of their papers today. So Dr. Shah attended the medical school at Yale and completed pediatric residency training as well as fellowship training in pediatric infectious disease and academic general pediatrics at the Children's Hospital of Philadelphia. His research focuses on improving the efficiency of care for hospitalized children with emphasis on common serious infections such as pneumonia and meningitis. He receives research support from the Agency for Healthcare Research and Quality, the Patient-Centered Outcomes Research Institute, and the Children's Hospital Association. Dr. Shah recently served as an associate chair of the National Pneumonia Guideline Committee, jointly sponsored by the Infectious Disease Society of America and the Pediatric Infectious Disease Society. He's authored more than 250 peer-reviewed research publications and greater than 100 chapters and reviews. In addition, he's editor or co-editor of 10 books in the field of pediatrics and infectious disease, including Pediatric Practice Infectious Disease from McGraw-Hill Medical in 2009, an infectious disease textbook written for the pediatric generalist, and the Philadelphia Guide, Inpatient Pediatrics. Dr. Shah received several prestigious research awards, including the Pediatric Infectious Disease Society Young Investigator Award and the Society of Hospital Medicine Excellence in Research Award, the inaugural 2015 Pediatric Hospital Medicine Excellence in Research Award, and the Academic Pediatric Association's Miller-Sarking Mentoring Award. So with all that, Dr. Shah, thank you very much for taking the time out to join us.
My pleasure. Very excited to be here.
All right, let's our conflict of interest while we're thinking about it. I have nothing to disclose. I have no conflict of interest.
I do not have any conflicts of interest either.
Okay. So now this topic is one of the more common things people are going to see. This is community-acquired pneumonia. Just to give our listeners an idea why we decided to do it, besides that it's on our core competencies for hospital medicine, from what I understand, it's the leading cause of hospitalization among children in the USA, with medical costs estimated to be approximately $1 billion, and that's in 2009. It's the leading cause of morbidity and mortality in children beyond the neonatal period, and it accounts for roughly 900,000 deaths approximately worldwide. And it does contribute to significant morbidity and mortality and healthcare expenditures in the developed world. Dr. Shah, what I think we could start with is the IDSA guidelines. So this is from the IDSA and the Pediatric Infectious Disease Society in August 30th, 2011. The lead authors, the first three authors were Dr. John Bradley, Carrie Byington, and you. There was just a slew of other authors. Now, the first off, one of the first things we should notice if you're listening at home about the guidelines is whom these guidelines are intended for. And they're intended for use by PCPs and subspecialty providers responsible for the management of otherwise healthy infants and children with community-acquired pneumonia in both the outpatient and inpatient settings. They even state that management of neonates and young infants through the first 3 months, immunocompromised children, children receiving home mechanical ventilator, and children with chronic conditions or underlying lung disease such as cystic fibrosis are beyond the scope of the guidelines or not discussed. We're going to focus mostly on the inpatient side, some of the outpatient side, but the caveat of otherwise healthy infants and children, that eliminates roughly half of, and this is a completely subjective, half of the kids I treat at a major children's hospital on the inpatient side. About half the kids I say I treat for pneumonia usually have a comorbid medical condition, so it's nice to know that these guidelines do not count for them. Now, it discusses the site of care management, antimicrobial and adjunctive surgical therapy, and prevention. Now, this is just the first page. So similarly to our UTI podcast, if you listen to that, we're going to kind of march through these, and I'm going to summarize them succinctly, I hope, to go through them with everybody. But, Samir, if I could ask you, is the reason the kids with comorbidities were left out simply because there just isn't enough research that has been done on them to really create a guideline for them?
Yes, that's one of the reasons. The other reason is that the current guideline has 92 recommendations, and the recommendations are so likely to be fundamentally different in children with compromising conditions, and the range of compromising conditions when you're talking about cystic fibrosis versus malignancy versus a neonate all require very different approaches. And so part of it was the lack of great data on some of these subpopulations, but also that the management strategies are likely to differ widely depending on the nature of the underlying condition.
So now, starting through, we're not going to go through all 92. If you're listening, please don't get nervous. We're going to really focus on the inpatient ones, but it is quite a few. So the first question is, when does a child or infant with community-acquired pneumonia require hospitalization, right? It's the most reasonable question to ask if you're an inpatient doctor. And the answer shouldn't surprise you. Respiratory distress and hypoxemia, which they define, just like for bronchiolitis, as O2 sats less than 90% at sea level. And this is one of the few recommendations where there was high quality evidence for. So remember, for these guidelines at home, there's different levels of evidence for each recommendation. Some of them is lots of randomized controlled trials, high quality evidence, and some of them are lower quality evidence where it's just expert opinion. The other 3 recommendations for when a child should be hospitalized with pneumonia are infants less than 6 months of age, anyone with a very virulent organism like community-acquired MRSA, and poor follow-up or questionable care at home. And those were low-quality recommendations. So the next thing is, when should a kid with community-acquired pneumonia go to the PICU or continuous CP monitoring? So obviously, if they're intubated, if they have non-invasive positive pressure ventilation or invasive ventilation, if they have impending respiratory failure, sustained tachycardia, inadequate blood pressure or need pressure support, and a pulse ox less than 92 on inspired oxygen greater than 50%, those kids should all be monitored. None of this should be a surprise. We're going to run through them. What test should you order in community-acquired pneumonia? Now, this one, I want you to remember this one, because it says for the outpatient side, blood cultures should not be ordered unless the child doesn't improve or worsens after starting antibiotic therapy. For the inpatient side, we're going to talk about blood cultures, because a few of the research that comes out that we're going to talk about comes from these recommendations. So moderate to severe pneumonia, particularly those with complicated pneumonia, should get a blood culture. A positive blood culture in someone who meets discharge criteria can still go home as long as there's close follow-up. Now, this is low-quality evidence, and a couple of other papers we're going to go over, like I said, discuss blood cultures in community-acquired pneumonia. It does warrant that when the guidelines talked about severe pneumonia, there was a table 4 they had, which had major and minor criteria, 1 major or 2 minor, that met that. I found it a little clunky, difficult to use, and I don't think I'd ever remember it, but it's there, and it may be something we have to reference later. Repeat blood cultures in children with clear clinical improvement are not necessary to document resolution of pneumococcal bacteremia. The difference is if the child has a blood culture which is positive for Staph aureus. The recommendations are you do repeat that to document resolution irrespective of the status of the patient, and that's a strong recommendation. It also recommends you get sputum sample for culture and gram stain in hospitalized kids who can produce sputum. The urinary antigen detection tests are not recommended for the diagnosis of pneumococcal pneumonia in children because false positive tests are common. I find this comes up more if I have med peds residents or faculty such as myself, because we do use it more on the adult side. So just as a caveat. CBC is not necessary in the outpatient, but those with more serious or severe disease should get it. Then ESR, CRP, procalcitonin cannot be used as the sole determinant to distinguish between viral and bacterial pneumonia. Some of the guidelines really have a way of what I find stating some of the obvious things, but I think it has to be said. So example is pulse ox should be performed in all kids with pneumonia if you suspect hypoxia. So that's there. Routine chest x-ray in the outpatient setting are not necessary. PA and lateral should be obtained in patients with either suspected or documented hypoxemia or significant respiratory distress, failed initial antibiotic treatment to make sure this is pneumonia, but also to look for a parapneumonic effusion, necrotizing pneumonia, or pneumothorax, and all patients hospitalized for community-acquired pneumonia. This happens at our hospital. I think it happens at most hospitals. I didn't know it was a recommendation in the guideline. That's just part of my ignorance on it. But it just happens all the time, so it is a recommendation. Anyone hospitalized should get a chest x-ray. Now, follow-up chest x-rays. They're not necessary if they recover. Repeat chest x-rays should be obtained in kids who don't have clinical improvement and or those whose symptoms progressed and if they deteriorate within 48 to 72 hours after initiation of antibiotic therapy. Kids with parapneumonic effusions don't need daily chest x-rays, but you should get one if they get worse, respiratory distress, clinically unstable, or the persistent fever which doesn't respond to therapy over 48 to 72 hours. The last one is repeat chest x-ray should occur in someone who has a recurrent pneumonia involving the same lobe as patients with a lobar collapse. So initially, if there's an anatomic anomaly, you get a chest x-ray. And it should happen 4 to 6 weeks after diagnosis. Other diagnostic tests they talk about: if you intubate, send a tracheal aspirate, get gram stain and culture, and any viral pathogen testing, including flu, once you intubate them. You should only get a BAL, which is bronchoalveolar lavage, bronchoscopy, or percutaneous lung aspiration, or open lung biopsy in immunocompetent children with severe community-acquired pneumonia if other diagnostic tests aren't positive. So, antibiotic therapy, we're running through them. Ampicillin or penicillin G to the fully immunized infant or school-aged child unless you have a locally documented high level of penicillin resistance in your strep pneumo population, Streptococcus pneumoniae. One of the biggest questions I get from residents is, now that we're not supposed to use third-generation cephalosporins, when are we supposed to use them? So the guidelines tell us that hospitalized infants or children who are not fully immunized, if we locally have high levels of penicillin resistance, and children with life-threatening infection, including empyema, should get ceftriaxone. Another recommendation, combine macrolide and beta-lactam antibiotics in the hospitalized setting when you think you want to treat the organism. So it's a little bit of a loose recommendation, but if you want to treat both, then use both types of antibiotics. And then use vanco and clindamycin when you want to treat Staph aureus. So one of the questions is that the guidelines goes over, what's the best duration of antibiotic therapy? 10 days has been studied, but shorter courses may be just as effective. Community-acquired MRSA may require longer treatment. Remember, a patient on appropriate antibiotic therapy should demonstrate clinical and laboratory improvement within 48 to 72 hours. And that's key. If you're on the right antibiotics, you should get improvement in that time, according to this. And now we're getting towards the end. Discharge criteria. I told you it would be fast. Clinically, so the discharge criteria for a hospitalized patient, according to the guidelines, are clinically improved for 12 to 24 hours, pulse ox greater than 90% on room air for at least 12 to 24 hours, stable baseline mental status, tolerating home antibiotic therapy, can take their pills or liquids. Parents can give meds to infants or young children, which should be obvious. If there's a chest tube, it has to have been removed for 12 to 24 hours. And there's a whole section at the end of towards the end of the guidelines on how to prevent community-acquired pneumonia, and the basic answer for anyone who's a practitioner out there is vaccinate anybody who can be vaccinated with anything they can be vaccinated with, is the summary of that. So Samir, since you're the third author on these, is that adequate as a quick run through, you think, for inpatient doctors for the guidelines, to give them just an idea what they have in them?
Absolutely.
Now, the last update was 2011. Is 2017. When do you think we could see another update of the guidelines?
We are in discussions with IDSA and the Pediatric Infectious Disease Society about the timing of the next iteration of the guidelines. So hopefully we will know shortly regarding the timing.
Okay, that sounds great. So the next paper we're going to do, and I promise you, if you're listening at home, we're going to talk to our guest more. We always have to start somewhere, and I always like to start the guidelines because it gives us a jumping off point, especially for this topic, for a lot of the research. And Samir, would you say that a lot of the research that we've done, that has been done since then, the guidelines have had a role in? A lot of people are looking at where there's low quality evidence and seeing if they can improve that.
Absolutely. One of the challenge with the inaugural edition of the guidelines was that there was a paucity of evidence to support a lot of the recommendations. You can see that many of the recommendations were supported by relatively low quality evidence, but the reality is you have to start somewhere. And so part of the goal was to highlight areas where future research should focus on, and a lot of the papers that we'll talk about today have targeted these areas.
The next paper we're going to talk about is new. It came out in JAMA in 2017. It's called Does This Child Have Pneumonia? The Rational Clinical Examination Systematic Review. It's by Dr. Sonal Shah, Richard Backer, David Simmel, and Mark Newman. And again, as in every podcast, I am likely to butcher numerous people's names. And I will apologize up front for all of it because I don't mean to, but I just don't know how to pronounce their names correctly. The reason for this paper, this was again on August 1st, 2017, so hot off the presses. The question asked by the study is, what is the accuracy of historical factors and physical exam findings in identifying kids with pneumonia? And specifically, they looked at radiographic pneumonia. So for this study, chest x-ray with a density that met the definition for pneumonia was what they used as a diagnostic tool, so as the standard. So there's differences. So just to review, there are differences in how physicians working in different places will diagnose pneumonia. We just went over this with the guidelines, but an ED doctor will most often get a chest x-ray diagnosis. But if you're in an outpatient setting, patient with cough and fever and some auscultation findings, that may be enough, and you may diagnose it in that way. The reference standard, or the gold standard, I believe, is an aspirate from the lower respiratory tract, which you get from either a bronchoalveolar lavage or a lung puncture. Just like I tell my patients, no one's going to, in their right mind, is going to take an average patient who's just mildly sick and maybe not hypoxic with pneumonia and do a lung puncture on them. That just doesn't make any sense. But it is useful, according to this, in the critically seriously ill child, life-threatening illness, those who don't respond to first-line therapy, or whose microbiologic infectious disease is critical. Identifying an organism is critical for directing further treatment. This study was a systematic review and a meta-analysis. Again, the chest x-ray was the pragmatic reference standard for the diagnosis of pneumonia. So the reason they used chest x-ray is it's well studied in literature, it's readily available in low resource settings, and it's less invasive than a BAL or lung puncture, obviously. They had to have some inclusion and exclusion criteria for the study. So the inclusion criteria for studies that they included are studies that had population including children younger than 5, patients presenting in outpatient clinics, EDs, inpatient wards with suspected pneumonia, obviously, clinical findings of either medical history or physical exam described in adequate enough detail to extract the data, and then outcome with a radiographic chest x-ray diagnosed pneumonia clearly defined on all children. And the exclusion criteria is all children had a diagnosis of pneumonia, very selective populations of patients like HIV positive patients or malnourished or rare diseases were excluded. Systematic review or retrospective studies were excluded. Chest x-rays not performed in all patients, they were tossed out. And test characteristics that could not be ascertained from the data provided. So the results, there was a whole section on this for statistical analysis where they talked about the likelihood ratio. We'll talk a little bit about that, but there's a lot we'd like to cover in the podcast today, so we're going to have to speed through some of these. They started with the 3,644 articles identified. Of that group, 404 were deemed good enough to be looked at, and then of those, 23 met the inclusion criteria and were selected. So looking at the studies, there was a couple things. 8 of them were conducted in North America, and 15 were conducted outside of North America. The rate of pneumonia in the U.S. Canadian studies was about 19%, and the rate outside of North America was about 37%. The difference in prevalence was statistically significant. So they looked at evidence for publication bias using the Begg-Mazunder rank correlation, and if you've never heard of it, it's just this is a test used extensively in meta-analysis to test for publication bias, and there was none. In the end, they felt that this was likely due to the difference in severity of illness of the population. Children in other countries, probably excluding Europe, would likely come in sicker and have more comorbid issues that just may not have come out in the studies. But they did not found any publication bias. So just to give you an idea, cough and fever was present in more than 80% of the children in most studies. And now the following results used likelihood ratios. And for those of you who are driving or just forget, and I had forgotten, let's quickly review likelihood ratios. They're used to assess two things: the potential utility of a particular diagnostic test. How likely is it that a patient has a disease or condition? It's basically a ratio of the probability that a test result is correct to the probability that the test result is incorrect. For the numbers, if the value is 1, then the test has no practical significance. So the further away from 1 the likelihood ratio value is, the more useful that result will be. So for medical history and physical exam and diagnosing pneumonia in kids, chest pain had a likelihood ratio of 1.9, which surprised me. Symptom duration of at least 3 days had a likelihood ratio of 1.2. But interestingly, cough, difficulty breathing, vomiting, and diarrhea were not associated with an increased risk of pneumonia. Their likelihood ratio included 1. What was interesting was the absence of cough was the only finding that had a likelihood ratio of less than 0.5. So without a cough, that lowers the chances that you really have a pneumonia. And then poor feeding was a likelihood ratio of 0.71, made pneumonia less likely. The vital signs section does have a couple of points I would like to bring up. Interestingly, O2 sats of 95% or less had a likelihood ratio of 3.5. That's rather high, well above 1, so it increases the chances that you have a pneumonia. But then O2 sats less than 90%, the likelihood ratio is only 1.5. So that means in this study, the sweet spot was between 90 and 95% O2 sats, where your probability of diagnosing pneumonia will be highest. I just found that number to be odd, 90-95%. I have no other reason. I have not seen other studies showing that. So is this something you've seen in terms of 90-95% is an area where pneumonia diagnosis may be higher?
It's hard to know the very practical applications of that finding. Conceptually, one way to think about this is if you have a virus, so if you have a viral lower respiratory tract infection, that you end up having diffuse lung inflammation, and so you are more likely to have significant hypoxia. And so kids who have what we think of classically as bacterial pneumonia, right, a lobar consolidation where the extent of inflammation tends to be a little bit more localized, it's very hard in the context of that sort of localized finding to have profound hypoxia or hypoxemia. And so that may be one way to interpret this, is that if you're, for lack of a better way to describe this, if you're a little bit hypoxic, you may have bacterial pneumonia. If you're a lot hypoxic, you're more likely to have a viral lower respiratory tract infection. Again, the sensitivity and specificity around what I just said is probably not particularly good, but in terms of conceptualizing how do you take this information and apply it to the patient, that would be one framework in which to think about it.
That's helpful. The interesting part is normal O2 sats, which they said was greater than or equal to 96%. The likelihood ratio is 0.47. So it makes sense if your child's not hypoxic, you probably don't have pneumonia. But for fever, they define fever as 37.5 degrees Celsius, which I found a little low. But that was a positive likelihood ratio of 1.7 to 1.8. And again, absence of fever that had decreased your chances. Your likelihood ratio is 0.17 to 0.37. Now, tachypnea, respiratory rate greater than 40 breaths per minute, that's what they first looked at, had a likelihood ratio of 1.5. And among kids 5 years and younger, a respiratory rate of less than or equal to 40 breaths per minute decreased the chances of getting pneumonia. So your likelihood ratio at that point was 0.5. So you had to beat 40 to have an increased risk. Auscultation, and this was something that I found interesting, and it may relate to a couple of things. For any abnormal lung sound whatsoever, the likelihood ratio was 1. There was just no difference. I just wonder if that's because viruses can cause abnormal lung sounds. Could it be that we're getting worse at auscultation as a group? I don't know. Or it's just a study, and that's what it found, and it may not mean much clinically.
It's probably a little bit of each of those.
Okay. Now, work of breathing seems to be where the money was at. So increased work of breathing, which they meant as grunting, nasal flaring, or chest retractions, had an increased risk. So the likelihood ratio for pneumonia was 2.1. And each one of those things individually was, I believe, flaring was 1.9 and the other two were 2.3 or so. But as a group, they're 2.1, but each individually increased your risks as well. So what they felt was the most useful triad of symptoms was chest pain, and this was, again, more in adolescent studies, but chest pain, increased work of breathing, and hypoxia to diagnose pneumonia. Now, we kind of went through their discussion as we're talking in terms of what was and was not interesting and how they discussed it, but they do say as a weaker point that the fact that they use chest x-ray as their diagnostic measure may overestimate the prevalence of a bacterial pneumonia that's actually there, which we'll get into a little bit in other studies. But I like this because it really talked about some of the things that we go through in terms of diagnosing pneumonia. I'm not sure how clinically applicable it is, except for the negative likelihood ratio. So if you have a child without hypoxia and without fever, irrespective of what you're hearing, and there's not having increased work of breathing, your chances of having a pneumonia are lower. I'm not sure that I would begin to parcel out what is more and less positive. Do you agree with that, Samir?
Yeah, I think there are a few things that struck me as particularly intriguing about this study. And I always wrestle with likelihood ratios, especially when they are not too far away from one. And we tend to draw, and we were taught, right, to draw this hard line at when your likelihood ratio exceeds this, then the test becomes useful. But there is a very practical application of this study, and I think chest pain is a really good example. The sensitivity is only 22%. So what does that mean? Sensitivity is, and the way I think about this, I frame my denominator first. So sensitivity is, of those with the disease, your sensitivity is the proportion with a positive test. So in this case, if the sensitivity of the chest pain is 22%, what it means is that most kids with pneumonia will not have chest pain. But if you look at specificity, the specificity is 91%. Specificity, the way I think about it again, is framing the denominator first. Of those without the disease, the specificity is the proportion of children who have a negative test. And so what the specificity of 91% means is that most children without pneumonia will not complain of chest pain. So if you have a child who has respiratory signs and symptoms and they complain of chest pain, my concern for pneumonia goes up substantially. But the absence of chest pain is not enough for me to rule out pneumonia.
That was a great point, Samir. Thank you. So now moving on to our next article. Before we do that, let's do a little interim in case people are driving. We'll keep you awake a little bit. It's time for some bad joke humor. Are you ready? What kind of dinosaur has the biggest vocabulary? The answer is a thesaurus. I promise you these will be bad. What does a clock do when it's hungry? It goes back 4 seconds. I just love these. Why did the toilet paper roll down the hill? To get to the bottom. Okay, back to what we're doing. The next paper we're going to talk about, this was a really exciting art paper. I did not read this till preparing for this podcast. The title is Community-Acquired Pneumonia Requiring Hospitalization Among U.S. Children. This was in the New England Journal of Medicine, February 26, 2015. The study authors were Seema Jain, Derek Williams, Sandra Arnold et al., and this was with the CDC EPIC study team, which stands for Etiology of Pneumonia in the Community. It was a prospective, multi-center, population-based, active surveillance study. It was done to determine the incidence and microbiologic causes of community-acquired pneumonia requiring hospitalization among U.S. children. So, Samir, what I liked about this is there wasn't a lot of these prospective multi-center studies for pneumonia in terms of what they're looking for. Do you agree?
Absolutely. And the studies that had been done were done more than a decade and a half ago, and the technology has really evolved. And while we don't always have great methods of pathogen detection that is clinically applicable in a relevant time frame, the technology, particularly around PCR and bacterial detection, had advanced so substantially since the last large study had been done. And this study is substantially larger, and the fact that it includes subjects from multiple centers makes it one of my favorite papers in the last few years.
And I'm going to ask you more on the topic of advancement of our technology in diagnosing or being able to identify organisms via PCR as we go through this, because they make a point of it in the article. But just to keep going with the article, this is an active surveillance. This occurred from January 1st, 2010 to June 30th, 2012. Like Samir just said, there was 3 hospitals in the study: Lee Bonhoeffer Children's Hospital in Memphis, the Monroe Correll Jr. Children's Hospital at Vanderbilt in Nashville, and the Primary Children's Hospital in Salt Lake City, Utah. So the inclusion criteria was children younger than 18 years old. They had to be in the catchment area. They had to have evidence of acute infection, which was defined as reported fevers or chills, documented fevers or hypothermia, or leukocytosis or leukopenia, had an evidence of acute respiratory illness defined as new cough or sputum production, chest pain, dyspnea, tachypnea, abnormal lung examination, or respiratory failure, and had evidence consistent with pneumonia as assessed by means of chest x-ray within 72 hours before or after admission. And just to be clear, the chest x-ray had to be confirmed by a board-certified pediatric radiologist at the sites. And they didn't know the clinical story, and they were included as authors. So the exclusion criteria were hospitalized recently, which was defined as less than 7 days for immunocompetent children and less than 90 days for immunosuppressed children, had already been enrolled in the EPIC study in the previous 28 days, lived in an extended care facility, had an alternate diagnosis of a respiratory disorder, or were newborns who never left the hospital. If they had a tracheostomy tube, if they had cystic fibrosis, cancer with neutropenia, if they received a solid organ or hemopoietic stem cell transplant within the previous 90 days, if they had bronchiolitis obliterans, or if they had HIV infection with a CD4 count of less than 200 per millimeter cubed, or CD4 percentage of cells of less than 14%. Right off the bat, I've noticed doing these podcasts that the really good studies, the exclusion and the inclusion criteria are big. They really take a lot of time out and thoughtfully look at who to put in, who to put out. And this study is no difference. So then how did they do this? So what they did was they had trained staff to obtain blood samples, acute phase serum samples, specimens, and nasopharyngeal and oropharyngeal swabs from all the enrolled children as soon as possible. Only specimens obtained within 72 hours before or after admission were included, except for pleural fluid, which was included if it was collected within 7 days after admission. If they happened to have pleural fluid and endotracheal aspirates and BAL specimens, they were also analyzed. There was a standardized questionnaire, and medical charts were abstracted after discharge, and desired info was taken. Then the children and their caregivers were asked to come back 3 to 10 weeks after enrollment for a follow-up interview. And they had convalescent phase serum collection. And just as a reminder, convalescent phase refers to the later stage of an infectious disease or illness when the patient recovers and returns to normal. But they can still be a source of infection to others. So the control, remember this is a prospective study, so they had a control, and it was from February 1st, 2011 to June 30th, 2012, a convenient sample of asymptomatic kids less than 18 years old without pneumonia were enrolled weekly. They took nasopharyngeal and oropharyngeal swabs to evaluate the prevalence of respiratory pathogens among asymptomatic kids, and those eligible controls usually were undergoing same-day elective surgery at a study site and were asked to be interviewed, and they were willing to be interviewed. And the exclusion criteria was the same as the ones in the study. When did the nasopharyngeal swabs at the study site sent for PCR analysis with the CDC developed methods for detection? They sent them to look for adenovirus, chlamydophila pneumonia, coronaviruses, human metapneumovirus, human rhinovirus, flu A and B, mycoplasma, parainfluenza 1, 2, and 3, and RSV. And then serologic testing for adenovirus, human metapneuma, flu A and B, paraflu, and RSV were performed at the CDC on available paired acute phase and convalescent phase serum specimens. So they have really set up a very nice arrangement to have so much analyzed for all these kids, which is why we get all this information. They said there was a pathogen if any bacteria could or should be there that you'd expect in a patient who's sick. So Haemophilus influenza, Staph aureus, strep pneumo, etc., was detected in blood, endotracheal aspirate, BAL specimen, or pleural fluid by means of a culture, or whole blood or pleural fluid by means of PCR assay. Or if chlamydophilus or mycoplasma pneumonia were detected in a nasopharyngeal or oropharyngeal swab by PCR. Then they describe what their definition of viral pathogens were, which they went into. And now for the results. I went through painstaking detail for the setup because the setup was just so well done. And it gives us an idea how good these results are going to be when we look at them. So the results, there was 3,803 kids eligible, 2,638 were enrolled, which is 69%. Of that, 2,358, which is 89%, had radiographic evidence of pneumonia. To check the radiologist's read to make sure that they were reproducible, they took 10% of a randomized sample, sent it to the other radiologists at the other facilities in the study, and there was roughly an 84% inter-rater agreement among the 3 study sites, and that's high. Samir, and you please feel free to comment on this, but an inter-rater radiologist agreement at that level is pretty good for a study like this.
That's pretty good. Right, we know the old saying, if you ask 5 radiologists to interpret a film, you'll get 6 different answers. Yeah. And so 84% agreement is quite good.
So now, just to go through some of the kids, the median age of the kids with pneumonia on a chest x-ray was about 2 years old. 45% were female, 40% were white, 33% were black, 19% Hispanic, 8% were other race or ethnic group, and then 51% of the kids had an underlying condition, with asthma or reactive airway disease being the most common condition. The mean length of stay was about 3 days in the hospital, and then 497 kids required ICU care, and of that, 3 died, unfortunately. 612 of the 2,053, or 30%, of the kids who were 6 months old or older had received 1 or more doses of the flu vaccine for the concurrent season, and about 87% of the kids who were 19 months to 12 years old had received 3 or more doses of pneumococcal conjugate vaccine. 18% of the kids had gotten antibiotics before they came in. 88% of the kids received antibiotics during their hospitalization. So I told you they did the nasopharyngeal or oropharyngeal swabs. They got them for about 2,254 of the 2,358 kids with a chest x-ray evidence of pneumonia, which is 96%, which is a big number. They got blood cultures from 91%, whole blood for PCR assays from about 87%, paired serum specimens from about 44%, pleural fluid from 4%, and a BAL from about 1%, and an endotracheal aspirate from a little less than 1% as well. For the proportion calculations of specific pathogens, the data were included only from the kids with radiographic evidence of pneumonia who had all the appropriate specimens available. So they tried to do their best to make the data look the way it should. A pathogen was detected in about 1,802 of the 2,222 kids who they looked at. So here's where we get down to it. 1 or more viruses was in 66%. And these are hospitalized kids at 3 major children's hospitals in the country admitted for pneumonia. 1 or more viruses was in 66%. 1 or more bacteria was in 8%, or 175 kids. Both bacterial and viral pathogens were on 155, or 7%. So if you include both, 1 or more bacteria, both bacteria and viral, that's 15%, which means that's a minority of the kids that are admitted for pneumonia actually have a bacteria that we can find according to the study. And that number, when I first looked at that number, and I realized about 66% of the kids that we admit, roughly, for community-acquired pneumonia in the hospital really just have viruses, it struck me as high. But Samir, I think you've seen other data that shows these are correct numbers. Is that right?
Yeah, these data are very consistent with prior studies, which right, these data demonstrate that the vast majority of children, especially younger children who are hospitalized with pneumonia, have viruses and viruses alone, either single virus or multiple viruses. In fact, if you look at they have some wonderful graphs in this paper, and what they show is that if you are younger than 2 years old, over 80% of these children have a single or multiple viruses and no bacterial pathogen identified. And tying this particular finding back to the National Pneumonia Guideline recommendations, or the guideline does actually state in recommendation 41 that antimicrobial therapy is not routinely required for preschool-age children with CAP, because viral pathogens are responsible for the great majority of clinical disease in this age group. What's also striking is over half the children 5 years of age or older also had viruses alone identified. So this paper really should influence how we think about pneumonia, which right now the default is a tendency to assume that it's bacterial, when perhaps we need to shift our thinking a little bit, and we'll talk more about that later in the show.
That's great. So the most commonly detected pathogens they found, and I'm going to state them in order of what they found. So RSV was in 28% of the kids. Human rhinovirus was in 27% of the kids. Human metapneumovirus, 13%. Adenovirus, 11%. The first sort of bacteria is Mycoplasma pneumonia at 8%. Parainfluenza at 7%. Flu at 7%. Strep pneumonia, Streptococcus pneumoniae is at 4%, then Staph aureus at 1%, Strep pyogenes at 1%. So we don't even get to a real bacteria until you're almost all the way down. Now, what did surprise me is Mycoplasma was so high. 8% of the kids hospitalized have Mycoplasma pneumonia. We know that gets more prevalent the older kids get. Is this increasing or decreasing, or we're not really sure, Samir?
We're not really sure. I mean, one of the big challenges with Mycoplasma testing is that there is a variable period of shedding from the respiratory tract, and so when you detect Mycoplasma by PCR during the initial presentation, it's not really always evident how long that's been there. If you've had Mycoplasma before, you may never mount an IgM antibody response again. What is curious in this study is that Mycoplasma was detected in almost 20% of children older than 5 years versus only 3% of younger children. And that's consistent with what we've known, that the older you are, the more likely you are to have Mycoplasma, but also not surprising that a small fraction of younger children also had Mycoplasma.
Yeah, I've been telling my residents that with daycares now offering kindergartens in the daycare, there's more mixing of kids at different ages than there has been. But I'm not sure if that's 100% the reason, or if we just don't know the reason.
The other thing that struck me about this was adenovirus, which accounted for about 15% of infections in younger children, in children less than 5, but only 3% of infections in children older than 5. So when you think about the age distribution of pathogens, this study has shed a lot of light on that.
I thought this was great. So, and then, of course, pneumonia peaked in the fall and winter, which we expect, which we're getting into, which makes this a little bit more timely. For the controls, interestingly, human rhinovirus was detected in 17% of the controls, as compared with 22% of the children with radiographic evidence of pneumonia who were enrolled at the same study sites during the same periods. And all other pathogens were detected in 3% or less. So rhinovirus is just ubiquitous, which we kind of knew. So using their diagnostic testing in this study, they did find a pathogen in about 81% of the children with pneumonia. Like we said, 73% had a virus and the bacterial is 15%. One of the things they discussed, Samir, was the differences in testing that have now begun to show a lower amount of bacterial pneumonia than previously reported, and simultaneously a higher level of Mycoplasma pneumonia. And they talked about, in the past, bacterial pneumonia, they used a PCR assay targeting pneumolysin, which is the pore-forming toxin of the bacteria Strep pneumo, when that test had a limited specificity. And it was done before the Hib and pneumococcal conjugated vaccines were released. Can you shed any light on how much better the testing has gotten? And is it purely because it's more PCR-based and we're looking at something else on Strep pneumo and the virus testing is also better? Is that why we're seeing these numbers shift?
Absolutely, or maybe not absolutely, but likely that with PCR you're not relying on identifying a viable organism and you're not relying on measuring an antibody response. And so you're looking at genomic material. And so the tests are much better at detecting anything that was ever there at any point. I think many of the folks listening to this podcast have probably had this experience of when we used to do rapid antigen testing, you would be able to detect something like influenza or RSV 5 to 7 days after symptom onset. With PCR, you can detect it much longer. And so we're seeing many children who are in daycare or other child care settings, when they come into the hospital, if you test them, it's not uncommon to identify 2 or 3 viruses in that child. And because of that, it's hard to know which of those viruses is responsible for the current hospitalization and which of those viruses was responsible for respiratory symptoms at some point over the past month or so.
Thank you for that. So now the next thing we want to talk about, let's do 2 more jokes and then we'll get into the blood culture conversation. So this one is nice. Why did Adele cross the road? To say hello from the other side. I love that. All right, one more. Why should you never write with a dull pencil? Because it's pointless. All right, so the next topic we're going to really bring up and try to talk about is blood culture in pneumonia, or more accurately, when to order a blood culture for a patient with pneumonia. There's 2 papers I would like to discuss. So the first article, and in no particular order, we'll do the older one first. This was a review article in Hospital Pediatrics, June 2015. Blood culture and evaluation of pediatric community-acquired pneumonia, a systematic review and meta-analysis. I apologize for this in advance. I'm going to butcher these names, but it's, I believe, Puying, Iram Tam, Ethan Bernstein, and et al., because I'm unable to pronounce the rest of the names, and I don't want to butcher them. So, Samir, before we talk about the ordering of blood culture in a patient with pneumonia, can you discuss a little bit about how these recommendations came about?
Absolutely. So one of the big challenges when the guidelines were being developed in 2010 and ultimately published in 2011 is that we didn't have a lot of information on how the epidemiology of pneumococcal disease was going to evolve. When the 7-valent pneumococcal vaccine was licensed, we saw a pretty significant drop in the overall prevalence of invasive pneumococcal disease. But when pneumococcal disease occurred, we saw a greater prevalence in resistance among those isolates. And some isolates like serotype 19A and serotype 1 were largely resistant, or what we call non-susceptible, meaning intermediate or resistant to penicillin, and the prevalence of these 2 serotypes was increasing. And so the 13-valent vaccine was released around the time that the guidelines were being published. And so we didn't have a great sense of which way things were heading. Were we going to see more resistance because of this concern for serotype replacement, meaning we see fewer infections caused by serotypes included in the vaccine and a huge increase in serotypes not included in the vaccine, or would we see an overall substantive decrease in invasive pneumococcal disease? And so it's important to remember that the guidelines were published in the context of that uncertainty. The intent of the guideline around blood culture recommendations was that how do you balance ensuring that we're making appropriate recommendations, but also being wary about being over-prescriptive in the recommendations when we didn't have great methods for assessing illness severity. As you mentioned, Tony, that the wording in the guidelines around the blood cultures was a little bit vague, meaning blood culture should be obtained in children requiring hospitalization for presumed bacterial pneumonia that is moderate or severe, without great definitions of what constitutes moderate or severe. And that was intentional because we don't have great ways of assessing illness severity.
That's a perfect segue into one of the things that we're going to talk about with these papers. Do you think we're any closer? Is there any better? From what I've read, I haven't found any that are very good, but obviously you're the expert on this. Are we closer to getting better guidelines in terms of moderate and severe pneumonia and ways of describing too clearly? Objective ways.
Procalcitonin is one biomarker that has shown a lot of promise in adults with pneumonia, and there's also been some work done in children with pneumonia. And I think other biomarkers are in development, and I think those things may help us get closer. But the other really important thing to appreciate is how important the pneumococcal conjugate vaccines have been in decreasing the prevalence of bacterial pneumonia overall.
I think that's great. So then let's adjust what we're going to talk about. What we'll do is we'll discuss your paper with Derek Williams from August 2017 on blood cultures, and then we'll go into a paper we have on procalcitonin, and I think we'll round out the podcast at that point. So this paper is called Utility of Blood Culture Among Children Hospitalized with Community-Acquired Pneumonia. It's by Mark Newman, Matthew Hall, et al., and it includes Dr. Samir, Shah, and Derek Williams, who've been on other papers, and the PRIS research the PRIS research group. This was in Pediatrics in August 23rd, 2017. And PRIS, in case you forgot, is the Pediatric Research in the Inpatient Setting.
Yep, PRIS, Long I.
Okay, PRIS, Long I, thank you. And remember, we talked about how they are in our guidelines. We talked about how they're not well defined. The question this study chose to answer was the prevalence of bacteremia and to characterize the microbiology and penicillin susceptibility patterns of positive blood culture results in a large multi-center cohort of children hospitalized with community-acquired pneumonia. And Samir just went through why they decided to do it this way. So the study type, this was a retrospective cohort study which used the PHYS Plus database. In case you're unfamiliar, the PHYS Plus database group is made up of 6 of the major large freestanding hospitals in the country that put their data in this extra database. So they included kids 3 months to 18 years old, hospitalized between January 1st, 2007 to December 31st, 2011. The pneumonia diagnosis was based on the ICD-9 with either a primary diagnosis of pneumonia or a primary diagnosis of pleural effusions with a secondary diagnosis of pneumonia. The exclusion criteria were children transferred into the PHYS Plus hospitals. Complex chronic conditions among their diagnosed discharge diagnosis, kids with secondary diagnosis of underlying chronic conditions. So now for blood cultures. Only blood cultures done on the first or second hospital day for each child was included in the cohort. Then they looked to see whether the organism was susceptible or non-susceptible to penicillin, and intermediate susceptibility was considered non. And for strep pneumo, or from the Streptococcus pneumonia organism was susceptible if the minimum inhibitory concentration was less than 2 micrograms per ml. For this study, patients were considered to have severe or complicated pneumonia if they were either admitted to an ICU or underwent a pleural drainage procedure on the first or second day of their hospitalizations, respectively. So you guys made a definition of severe pneumonia for this study.
Correct. And that was predicated just on what was very practical with this database. And so this database includes billing data from the Pediatric Health Information System, or PHYS, and that includes demographics, ICD-9 discharge diagnosis codes. It includes what medications were administered. It includes resource utilization data. It also includes what tests were ordered, and we merged that with clinical, laboratory, and radiology information from these 6 hospitals to create this new database called PHYS Plus. And so it's very robust because it includes actual microbiology data. So we knew not only who had a blood culture sent, but we had the results of that blood culture, including the organism and its susceptibility pattern.
Samir, the PRIS and PHYS Plus acronyms for the research group and database respectively, the acronyms are so similar. Sometimes I confuse them, but are they related?
It gets confusing because the database was created by members of the Pediatric Research in Inpatient Settings, or PRIS network. And so PRIS, PHYS, long I, short I.
I didn't know that part.
Very easy to get those two things confused.
So now, for this study, a total of 14,166 community-acquired pneumonia hospitalizations were identified at the 6 study sites. After all the exclusion criteria were used, the final cohort was about 7,509 community-acquired pneumonia hospitalizations. And interesting, when you broke down the demographics of who got the blood cultures, you found that kids who had blood cultures done were more likely to have private insurance, present during the summer, and have a longer hospital stay, which was just a point you brought up, which I thought was interesting. Overall, bacteremia was identified in 0.9% of the 7,509 hospitalizations. Only 2,568 patients of the 7,509 had a blood culture obtained. So of that, 65 of them, or 2.5%, demonstrated any growth in their blood culture. Of that 65, 51 had Streptococcus pneumoniae, which was the most common organism identified. And then another 25 or so patients had contaminants. 25 or so blood cultures were contaminated, with coag-negative staph being the most common contaminant. So 61 of the 65 positive blood cultures had susceptibility information. 50 or 82% were susceptible to penicillin, including 92% of the Streptococcus pneumonia isolates. And 11 kids had growth of a pathogen non-susceptible to penicillin, which represented 0.4% of all the kids who had a blood culture, which is a small number. And then the rate of bacteremia with the pathogen was not different among the subset of children treated with antibiotics on the first or second day. So these numbers are very small, and there was only a few detected pathogens. Streptococcus pneumonia was the most common, and most pathogens were susceptible to penicillin, over 90%. So this makes you think that routine blood culture has limited value in the majority of kids hospitalized with community-acquired pneumonia because it won't change therapy. But there was still a rationale, you said, for obtaining the blood culture in children with moderate to severe community-acquired pneumonia because, A, you can focus therapy when there's a pathogen, and this allows you to broaden therapy if the patient's not improving. So then you also pointed out that kids with empyema or an ICU setting have a twofold higher yield of bacteremia with blood cultures. So children in the ICU, because of their pneumonia and or had an empyema, their chance of getting a positive blood culture is higher. And then you talked a little bit about the contamination rate, which was high at 40%. And they can contribute to longer hospital stays, increased exposure, unnecessary antibiotics, side effects, cost, etc. So what I took from this, and Samir, tell me if I am completely wrong, is that the yield of blood cultures low among your average healthy child who may be in and out of the hospital in 12 to 24 hours with a mild or moderate pneumonia. The problem is you just can't tell who is going to worsen when they're in the hospital. So if they're in the ICU or if they have an empyema, the yield is higher. But I felt it was hard to make a distinctive decision on who to order, who to not order based on the study. But what do you think?
Yeah, and my thinking on this has evolved over time for sure, that, blood cultures and the isolates from blood cultures played a pretty major role in helping determine what serotypes were included in the original 7-valent pneumococcal conjugate vaccine. But what we've learned since then is, because we're seeing a lot less pneumococcal disease in particular, the yield of blood culture has become incredibly low, and we may be at a point where we're seeing diminishing returns. In our study, the overall rate of bacteremia in those who had a blood culture performed was 2.5%. But the good news in all of this was that penicillin non-susceptible organisms were isolated from less than 0.5% of children with blood cultures performed. So if we're using penicillin or amoxicillin or ampicillin as first-line therapy, even if you have a positive blood culture, odds are that the antibiotic you're receiving, that narrow-spectrum antibiotic, will actually provide adequate coverage for that. In fact, our calculations that we presented in discussion were that you would have to obtain a blood culture on 223 children to identify one child who would require broadening of antibiotic coverage beyond amoxicillin or ampicillin. And to me, that's very compelling data to say that there's an opportunity to be much more selective about whom we obtain blood cultures on. The dilemma remains, as you point out, how do you identify those kids up front? It can be challenging because we don't have great illness severity prediction scores just yet. And so right now, at this point, it is based on clinical judgment, but among the things that one might consider in their decision-making is, how sick is this child? Meaning, if the child is likely to be admitted to the ICU, it's probably very reasonable to get a blood culture. If the child is going to the regular ward, does not have significant tachycardia or other findings that make you concerned about clinical deterioration, again, it may be okay not to get a blood culture in those circumstances. And so there is an opportunity to have a much more targeted approach to obtaining blood cultures. The other big point here is, where is the world going? Biomarkers are being developed, and so as time moves on, we will have better and better ways to identify kids who are exceedingly low risk of bacterial infection and who probably don't warrant blood cultures. And part of the challenge is, right, the trade-off of false positives versus identifying a pathogen to which the antibiotic you're on is ineffective, or if you didn't receive antibiotics in the first place, should you be started on one? If you feel ready, this may be a great time to transition to this, to talk about procalcitonin a little bit and some of the great work that Chris Stockman and Derek Williams and others have done on procalcitonin and identifying children at low risk of bacterial pneumonia.
I think you're right. Let's do it. So this is an article that we're going to discuss. Procalcitonin accurately identifies hospitalized children with low risk of bacterial community-acquired pneumonia. This was in the Journal of Pediatric Infectious Disease Society 2017. This was again done by Chris Stockman, Crow, Empofo, Jarrett Kilpack, and then Derek Williams. So this is procalcitonin. So in case you're at home and you're wondering what this is a peptide precursor of the hormone calcitonin. It's produced by the C cells in the thyroid gland and by the neuroendocrine cells in the lung and intestine. In healthy individuals, serum procalcitonin concentrations are low or undetectable, less than 0.1 nanograms per ml. However, they usually markedly increase in patients with confirmed bacterial infections. In adult procalcitonin concentrations have been used to guide the initiation and duration of antibiotic therapy for patients with community-acquired pneumonia. So this study was done by that group to assess whether serum procalcitonin concentrations were associated with the type of pathogen detected and disease severity in a large, well-defined cohort of children hospitalized with radiographically confirmed community-acquired pneumonia in the U.S. So 2 hospitals were used, Primary Children's Hospital in Salt Lake City, Utah, and Monroe Carell Children's Hospital in Vanderbilt in Nashville. The patients used were the same children in the CDC and Prevention's EPIC study we talked about a little bit earlier. Remember, the EPIC study was that big multi-center population-based study. And to review, we talked about how they did it, what a typical bacteria was. From that study group, 532 patients had residual serum obtained at the time of hospitalization available for this study. They used in this study. The residual serum was frozen at negative 70 degrees, and the procalcitonin testing was done retrospectively. These results were not available to the clinicians. So what were the results? Typical bacteria with and without viral and or atypical bacteria co-detection was in 54 kids, or 10% of the children. Atypical bacteria with and without viral co-detection were detected in 82 or 15% of the children, and viruses alone were detected in about 66% of the children. Remember, these were all kids who were hospitalized. In fact, 87% of the kids received inpatient antibiotics. So severe outcomes, about 185 of them were in the ICU, about 35% of them. Invasive mechanical ventilation occurred in 11% or 57 kids, and a parapneumonic effusion occurred in 34 or 6% of the kids. Median procalcitonin concentrations were higher in those with typical bacterial pathogens detected, which is about 6.1 nanograms per ml, compared with those with atypical bacteria detected. And those levels were 0.1 nanograms per ml. So just to recap, a typical bacterial pathogen causing community-acquired pneumonia, the median procalcitonin concentration was 6.1 nanograms per ml, and those with atypical bacteria had 0.10. So it's a huge difference. If there was only a viral pathogen detected, the median procalcitonin concentration was 0.44 nanogram per ml, or no pathogen detected, it was also 0.44 nanograms per ml. So procalcitonin levels were similar in kids with typical bacteria infection alone versus those with bacterial and viral co-infection. When they used a cutoff of less than 0.25 nanograms per ml, the sensitivity of procalcitonin for the identification of children with typical bacteria was 85%. And that's with a 95% confidence interval, with a specificity of 45%, and a positive predictive value of 17%, but a negative predictive value of 96%. A procalcitonin concentration of less than 0.25 nanograms per ml was associated with a 5-fold lower odds of typical bacterial detection. But if you lowered that cutoff to 0.1 nanograms per ml, that increases the sensitivity to 100%, but it decreases specificity to 20% and the positive predictive value to 15%. This is one of the major points of the paper, but that when procalcitonin is low, the odds of having a bacterial infection are also very low, and you can almost put it in the bank.
Yeah, Tony, that's a very important point from a direct clinical application of this study. If your goal here in using procalcitonin is to make sure you don't miss a case of bacterial pneumonia, meaning that you're going to use procalcitonin to help you decide who doesn't need antibiotics, then a low procalcitonin can inform that decision. So as you point out, a procalcitonin of less than 0.1 was associated with virtually no one, or in this case, actually no one with a bacterial infection. The other way to frame that is the negative predictive value of the test was 100%, with a lower 95% confidence interval bound of 94%. That means if your procalcitonin is less than 0.1, you can feel very comfortable that this child is highly unlikely to have a bacterial infection, and that's a child you may choose to forego antibiotics with unless their clinical status changes.
Samir, thank you for that great explanation. That really helped bring it all home. Let's finish up the rest of the paper. Procalcitonin was also significantly higher among children with empyema, which was 2.94 median, compared with those without empyema. So after adjustment for age and detection of a typical bacterial pathogen, procalcitonin concentration less than 0.25 nanograms per ml was associated with a reduced odds of ICU admission, which is similar to what we're talking about.
What I found intriguing about this was that 20% of children with a procalcitonin concentration of less than 0.1 nanograms per ml required admission to the intensive care unit. In contrast, none of the kids with a procalcitonin of less than 0.1 had a bacterial infection identified. What that means is that some of the things that make you sick within the context of pneumonia are not bacteria but viruses. And so maybe procalcitonin is a very good predictor of who doesn't have a bacterial process, but it's not a great predictor of who's going to get sicker.
I think that's a great point. I think that's a good point to end on, too, because it does help you to figure out who does or does not need antibiotics, which may help with what we do, but whether or not the child gets sicker may have nothing to do with it at all. Ladies and gentlemen, we are running out of show. For those of you listening at home, there were other articles I wanted to cover, but we just simply don't have the time. Next year, I may redo this topic as 2 separate 1-hour podcasts. We'll see. What I hope we did today was refresh your memory on the community-acquired pneumonia guidelines, give you some of the newest and clinically significant research that's helping us take care of patients and helping to change some of those guideline recommendations that were expert opinion or lower quality to higher quality recommendations, and shine a light on some of the excellent researchers who are doing this work, like Dr. Samir Shah and others. Staying with that thought, I wanted to thank Dr. Samir Shah for taking the time out of his very busy schedule today to sit and talk with us about community-acquired pneumonia. Samir, it really was great having you on the podcast. I hope you think, well, let me ask you, do you think we did a reasonable job in reviewing this topic that's so important but large and big?
I think we did pretty good. So you reviewed the guidelines. We touched upon some of the antibiotic therapy, blood cultures, procalcitonin, and the physical exam stuff.
So
not too shabby.
Not too shabby. So to summarize again what Dr. Shah just said, we did start the podcast by reviewing the community-acquired pneumonia guidelines from 2011. We then went into the use of history and physical and in diagnosis of pneumonia, the recent paper from JAMA in August 2017. We examined the microbiological causes of community-acquired pneumonia on the inpatient setting via the EPIC study. And if you remember, what we found out was that viruses are still the most common cause of inpatient hospitalized community-acquired pneumonia. We looked at the blood culture usage in community-acquired pneumonia, and then we discussed the use of procalcitonin to help decipher between a viral and a bacterial cause of community-acquired pneumonia. But again, don't forget, we did make the point, or Dr. Shah made the point, that it does not tell you the severity of illness of the patient, meaning a patient with a viral cause of community-acquired pneumonia may still end up in the PICU. Which of those who take care of these kids know that? Just a reminder to our listeners while I'm thinking about it, there is free CME associated with the podcast thanks to the University of Pittsburgh. If you just click on the link wherever you're getting the podcast, there should be a description of it. There should be a link. If you fill it out, you're welcome to the free CME. I'd like to remind everybody about that. I want to take the time out again to thank our guest, Dr. Samir Shah. Thank you very much.
No, I think this was great. Thank you very much.
I would like to do a couple of acknowledgments, if that's okay. I'd like to thank the Paul C. Gaffney Diagnostic Referral Group at Children's Hospital of Pittsburgh for continuing to support the podcast. I would like to thank, as always, Dr. Megan Keene Tarchichi, who truly helps me with everything. I would like to thank all of our listeners and all of our listeners at home. We don't have any viewers. We're a podcast. Thank you very much for listening and downloading. I sincerely appreciate it. What I would like to tell you is if you have any comments, requests, podcasts you'd like to hear, anything at all, please feel free to email me at tony.tarchichi@chp.edu. That's tony.tarchichi@chp.edu. I'll be sure to respond and see what we can do. Next time on the podcast, we are hoping to get and working on getting the lead physician for the emergency disaster preparedness at Texas Children's Hospitals at Baylor in Houston, Texas, to discuss some of their preparedness and preparation techniques and what happened during Hurricane Harvey when the floodwaters came rushing in. But of course, that's still up in the air, so we'll let you know once we know. Thanks again, everybody. Have a great day.